Thanks for listening. If you'd like to schedule a one-on-one coaching with Dr. Lodi, please visit drsadaf.com. I am an American board certified OBGYN, a mom, a Muslim, and I'm talking about sex. This is the Muslim Sex Podcast. Hey, assalamu alaikum.
Assalamu alaikum. How are you?
Good. How are you? I'm so excited to have you on.
Oh, thank you. I was rushing back from clinic and I was like, I really hope I'm not late. And then I saw your message. And so, sorry, I'm all a bit out of sorts because it's Friday here. Yeah. And the Jummah prayers just happened. And when I live very close to the mosque, which is about 2 doors away. And there's just so many cars on the road that block you in. So I was like, oh my goodness.
Well, I'm sorry.
Thank you so much for having me, honestly.
No, I'm so excited to have you on. So I want to know all about you. And I see that you is it a documentary on endometriosis or Below the Belt?
Yes. Oh, gosh, I'd love to talk about that. So just want to say, Jummah Mubarak, hello, everybody.
Yes, please. So if you could just introduce yourself to our guests. I'm sure most of the people know who you are, but for those of us in the US, if you could introduce you.
Yeah, hi everybody, and thank you so much for joining our Instagram Live. I'm Dr Nighat. I'm an NHS GP in England. So I'm just outside of London in a small area called Buckinghamshire. That's where I live and work as well. And my specialism as a GP, because we're family practitioners, is that I also do women's health. In that I do menopause as well. And that really came about because when we are training, as you know, Safa, we go on different rotations, and the need for women of colour, for women who don't speak English as a first language, and I speak Punjabi from Pakistan, I'm from Lahore.
Woohoo!
So, you know, that's the culture that I've grown up with. But there's a real need for women to have access to know how to navigate the healthcare system in the UK. Along that, pandemic hit. And when the pandemic hit, I started doing more on social media in regards to raising awareness around women's health. So last night, Wednesday night, I went to the premiere of a movie called Below the Belt. I know, honestly, I have to clap this woman because she is phenomenal. And the movie is a decade's work.
Wow.
Put down under an hour and a half. And it's following 4 women, different ethnicities, different backgrounds, socioeconomic backgrounds as well, in Northern America. One I think is in Canada as well. And what it does is it follows their journey through pain, really, and the fact that the key things that stood out for me was that, one, their pain wasn't believed. And I think that's something that I'm sure you get with your women from your community.
Yes.
No one knew the diagnosis of endometriosis. There was very little known about.
Wow.
There's no test for it. You don't see it on an ultrasound scan. You can't see it even on an MRI. And sometimes you miss it on a laparoscopy as well. And then there was no treatment. There's no cure for endometriosis. And so Shannon Cohen, she won't mind me sharing this because she shared this with everybody. She's also an endometriosis sufferer. And she went on a personal journey because she hadn't realized that as you know, she has endometriosis, but she can pass it on to her daughters, or her daughters can also have endometriosis as well. And then she just thought, right, I need to raise awareness about this. And she made this phenomenal movie just to highlight to healthcare professionals, these are the issues. Please, can we make sure that women aren't being missed? And there's a global conversation happening around women's pain and women's health anyway.
Yes.
And it's produced by Hillary Clinton. So it's a real honor to go to the EU, you know, the European premiere. And hopefully I think it's going to go out into mainstream soon.
That's so exciting. That's so exciting. So, you know, with endometriosis, as you know, I'm sure, is that, you know, the amount of disease doesn't correlate to the amount of pain. So you could have tons of disease and not experience much pain, or vice versa, right? Not have much disease and have a lot of pain. So you're so right about that. I know here that we sometimes do like Lupron or something to stop the menses, so that, you know, women don't have that much pain. But you're right, there isn't much treatment. And sometimes, you know, with laparoscopy, we can go in and burn those lesions and things like that. But yeah, I mean, you know, it's supposed to get better after menopause, but you're right. I mean, there is, you know, a lot of pain with endometriosis, and a lot of times it's hard to diagnose. And sometimes it's a diagnosis of exclusion.
It is a diagnosis of exclusion. I think people underestimate that it can start relatively young. So on average, the statistics is that 1 in 10 women will suffer from endometriosis. It takes roughly about 7 to 10 years to diagnose, because we don't believe that it is a diagnosis. One, because we don't have a test. And as healthcare professionals, so in England, in the UK, we have the NHS. So we are limited cost-wise sometimes of what tests we can do. So we first start off by the woman presenting to the family physician, the GP, such as myself. And we're generalists. We do everything, and then we might develop a specialism within us. And I remember, I don't know about you, Sadaf, but at medical school, I probably had one slide telling me what endometriosis was. And it was almost like, oh, but it's manageable because you just give women some pain relief or put them on the contraceptive pill and stop them having periods.
Right.
Because endometriosis, the definition for those watching, is cells similar to the lining of the womb, which get deposited in the pelvis, and causes, like you were saying, a spectrum of symptoms. To somebody could have like grade 4 endometriosis and have no symptoms, to the point where someone can have few specks of endometriosis and they can have painful periods, painful sexual intercourse, bowel problems as well, difficulty passing urine. They can have severe cramps. They can have real issues in regards to fertility, subfertility, loss, pregnancy loss as well. And I think that what the movie highlighted was that the dignity that comes along with women's pain, and how firstly they're not listened to, and secondly that they lose everything. They lose their presenting to A&E wanting morphine. They're seen as drug addicts.
Yeah.
And then wanting to, you know, think about, well, I want to try for a baby, but then being pushed, well, have the Mirena, or, you know, a long active contraceptive, a LARC, that will stop this, and not really giving them a solution. And in the US, you know, one of the women on the documentary, I mean, her dad took out a second mortgage to pay for the surgery that his daughter needed to burn away the ablation. And I think the difficulty is that the pathway is set in a way, in the UK particularly, is where we will say this is a condition where it's long term, but it's just a management condition. And where does fertility come into it? Where does planning your babies in the future come into it? And then where do we find that surgery plays a role, and the complications? Because even if you have surgery, unfortunately, as you know, it will come back for some women. Yes. And then we manage that level, because it's so variable. It's such an individual disease. And where do we get the awareness so healthcare professionals can diagnose it early enough to get the intervention in? And I think the barriers to those bits of healthcare are the things that we're still fighting for at the moment. And that's an ongoing conversation that we need to constantly have.
Right, right. And as you know, endometriosis is responsive to, you know, the estrogen, right? So even if you get some of that disease taken care of, if you have little lesions throughout the pelvis, you know, every time we have that estrogen that's present, you know, you can still have pain. You can still, it doesn't really get you know, you don't really get rid of all of that pain. So you're right. It is a persistent disease. It is very difficult for women that suffer from it. Absolutely. Absolutely.
Yeah. And I think the biggest thing is that women are resilient. Like I always say that you know what pain is from the age of what? The average age of starting your periods is about 10 now, because it's getting... So we are built to resist pain as women. Yeah. Right. And we, you know, ask a boy at the age of 10, do you know what pain is? And probably will just say, oh, I've scraped my knee. But this is a month of pain.
Yes. Yes.
Young girls too. And yet we still don't have a way of managing that. And one of the other things that I do is that I insert coils for my patients. And at best, depending on the information that they're given, and sometimes, I mean, I've had some horrific stories, but they're told, oh, take some paracetamol and some ibuprofen before you come for your coil insertion. And you're like, what? This is a coil insertion? And they're coming in their lunch hour to have it inserted, and then they're back on the bus to go back to work. Whereas I used to sit in and assist in vasectomy clinics. And here you can have, depending on which area that you live in, you can have a vasectomy on the NHS. And there's a rigorous process where you counsel the man, you go through it. This is, you know, you're having a vasectomy, your fertility will be affected. You know, there's 1% chance that you might have chronic pain afterwards. And then we give them local anesthetic. And then get this, they can have, in some areas, they can have a sick note for work for up to 6 weeks.
Oh my gosh. Oh my God, that's amazing.
It's amazing, isn't it? And then women will have a coil in their lunch hour, get on the bus and go back to work, and then run a team. And it's crazy how
that is crazy.
Balance completely between, you know, healthcare and management of pain for men and women.
Yeah, absolutely. So just for the people in the US that don't know what a coil is, so that's an IUD, right? You're talking about an intrauterine device.
Yeah. Sorry.
Yeah. No, that's great. And then the paracetamol is the Tylenol that we call here. Tylenol. Yeah. So that's amazing, right? Like the difference. Like, and I've seen vasectomies. When I was a medical student, there was a family practitioner that used to do them in his office. And you know, they're not like a involved procedure. I mean, it's pretty easy, you know, to do. And he used to do them like just in his office.
Here the same. You do them in a GP surgery. You set aside a room for a clinical room. You know, it's not a major operation. I would say having an IUD, you know, a coil, as we say in the UK, inserted into the uterus is far more invasive, because you've got to clamp the uterus, you know, get it inside, put a sound in to check the depth of the uterus. And so it's far more complex. And we don't offer, I mean, some women will say to you, look, we were offered nothing.
Yes.
And I think women's pain is something that's is shrouded with so many different factors, but at the bare minimum, we should be saying, well, we're going to have an invasive procedure done on you. Let's make the position where we can give you a cervical block. I mean, cervical block is an injection into the neck of the womb, so that can be sore in itself. But I use lidocaine spray. That really numbs the neck of the womb, and I use Instilogel. Instilogel just helps having a speculum inserted into the vagina. And also, if you know that a woman might have vaginal atrophy, if you're putting a Mirena coil in for as a component of HRT, then prepping the woman 3 months in advance and go on vaginal, as my colleague Dr. Rachel Rubin always says, vaginal, sorry, go on vaginal estrogen for, 3 months or so before you come in and have this procedure, because not only have you had pain from the procedure, but now you're having pain because you've got a speculum put in when there's vaginal atrophy there. And it's being mindful of this, and unfortunately we have that disjointed care that we forget that. Yeah.
Absolutely. No, you're definitely correct about the vaginal atrophy and, you know, the pain with the speculum, and absolutely, you know, I actually had 2 IUDs placed, and no one ever offered me any like type of cervical block or anything like that, you know, and we forget that it is painful, right? Yeah. And you saw that on social media where everybody was talking about IUD insertion and how painful it is, and how we don't, especially here in the US, you know, we just say, oh, it's, you know, it's a quick procedure. It's a little bit uncomfortable, but, you know, you'll be fine. And I think we're just used to like the pain that women go through in labor, right? And how painful that is. And we think, oh, well, IUD insertion is nothing compared to that, right? Whereas when you're talking about with men getting vasectomies and getting 6 weeks off, that's really amazing.
That's across the world, but I know when I did it in my area. Yeah. I had a gentleman who insisted that his employer gets a 6-week notice that he was going to be off because he'd had a vasectomy. And the story has stuck with me, and I was a junior trainee then. And I just, even then I was thinking, like, you're going to tell your employer, I mean, he got paid sick leave for 6 weeks. And I just thought women never would even have the guts to ask, I think.
I know.
Like they would, you know, they wouldn't even tell their employer, look, I'm going off to go and have a IUD insertion. They would rather say, I've got a sore throat or a headache.
Yes. Yes. You're so right. You know, there's so much shame and taboo, you know, around our bodies and, you know, what we're willing to share and be open and honest about. But I want to know so much about you. So tell me about your journey. And, you know, you just went to Buckingham Palace. I saw that. That was exciting.
Yeah. Oh,
great. So tell us.
I'm an immigrant. I always start there. I mean, I wasn't born in the UK. I came from Pakistan when I was 9 years old. And this is, to me, is home. And I feel very much a British Pakistani, grounded in my roots. And I think that with sometimes the negativity that we get around migrants is really hard. But in the US, I think there's less so because it's a country made up of migrants. Whereas in the UK, we still have those issues around, you know, are you really from this country? So we do have institutionalized racism, and actually that's recognized in the latest SAGE, which is these government reports that they bring out, which under COVID, we were looking at deaths among Black, Asian, ethnic minority communities. And we'd had, you know, in some cases, 90% deaths have, or adverse reactions happened in ethnic minority communities. And one of the outcomes was because of institutionalized racism in this country. It's not as bad, but it's hidden. And I think sometimes that's really quite more distressing, and that seeps into all institutions. And so we really need to say that even the NHS, the biggest employer in this country, is made out of immigrants. So I'm a very proud immigrant. I'm very proud to be Pakistani as well.
Yes.
My heritage. And came here and learned how to speak English, integrated into the system, went into medical school because I just thought, the reason I went into medical school, and then you're going to laugh at this, Safda, is because I just thought, I don't want to get married. Like, the thing was that, ye ladki badi ho rahi hai, you know, this girl's getting older. My parents were like, I'm the eldest of 5. What are we going to do with her? She's very outspoken. Let's get her married off. And I was like, I'm not getting married off. I'm going to go into prison. I was like, 5 years, give me 5 years.
That's awesome.
Yeah, exactly. So I went into medicine because I just thought, this is great. I can have some freedom. And then I studied in London and got my medical degree, and then did all my, you know, residency or house jobs or house officer jobs. Got my license to practice as a GP. And then I did get married, and actually I did the very good thing. I say good thing, not that there's any bad ways of doing it, but my parents said, who do you want to get married to? And I said, well, I've got no one. I'm very scatty. And they were like, well, should we find you somebody? And I said, yes, please do. And yeah, then I had a very lovely arranged marriage, and he's stuck with me now for 16 years. So I think the arranged marriage went okay.
That's fantastic.
And now he sort of puts up with a lot. And the amazing thing is this misconception about, even when I was having this arranged marriage, because we hadn't met, we didn't even see each other.
Oh my gosh.
My friends in medical school were like, तुमने उसे देखा नहीं है, कैसे, जैसे तुम उसे जानती भी नहीं हो. And they were so surprised because he's from Pakistan. But I know him very well. So he's a couple of villages down from the village that I was born in.
Oh my gosh.
You know, I'm from the village, you know, everybody's from, you know, farmers, you know, zameen wale and some. So I was like, that's fine, it'll be okay. He's a barrister, and I knew on that front we'll be fine. And honestly, I've married the male version of me. And
oh my
lovely. There is, he's a human rights and immigration lawyer now.
Oh, that's great.
His own law firm in London. But it was amazing because I think that although I think you can take someone out of Pakistan, but you can't take the Pakistan out of that person. And I'm that individual, whereas, you know, I will wear my dupatta, I will wear my shalwar kameez, and even at work sometimes, because even though I'm very much British in that respect, but your cultural heritage and your roots are the things that ground you. And so being grounded is really important part of, I think, growth in the future as well, because you feel that you belong. And one of the things that you have as immigrants is that your sense of belonging, where do I belong? Either you keep finding someone to hold on to, an institution to hold on to think this is where I belong, or you find it within yourself. And so for me, my faith and obviously my heritage is that thing that gives me belonging. So fast forward to the pandemic, and the BBC approached me and said, do you want to be one of the doctors who's talking about COVID? And I said, I will, but I want to remain as I am, and I will keep my hijab as I wear it, and I will wear my shalwar kameez, and I'll talk about COVID. I'm not going to talk about terrorism as a Muslim woman, because that's what everybody expects you to do.
Right.
And or I'm not going to bake you something, or I'm going to cook you something, because there's this assumption that, you know, Musliman aurtein bas pakati hain aur agta ke bas.
Yeah.
There's nothing wrong with that. I love cooking. I mean, I spend most of my time in my kitchen, which is where I am at the moment. But there is this misconception that jo aurat hijab dalti hai, the woman that wears a hijab or dupatta dalti hai, wo bahut, like, she's backwards. I don't know. Do you still find that? I find that sometimes.
Not so much here. I don't think that well, sometimes, you know, people might think that they're more traditional, but
Yeah,
but
is that
not.
feeling that she's more traditional, the fact that she's more reserved, or this is the thing that really, really infuriates me, is that they think that you're a better Muslim.
Yes.
You're just because you cover your head.
Yes.
Tum achhi Musliman ho. That makes me so angry. There are very few things in life that make me angry, but that's one of the things that make me angry. And the reason that is because the misconception of what hijab is. Hijab isn't just covering your hair. Hijab is of your eyes, of your mind, of everything. And so if you could cover your hair, but have absolutely, you know, no moral. That's ridiculous. To judge someone just because of the basis of their looks is ridiculous to start. And I think it was really the fact that I thought, I just want to stay as authentic as possible, yet do my medicine, which I love and enjoy, and give it out on social media to individuals, because it's very rare that we get seen or heard, unfortunately, as women of color and migrants, and also women who, you know, are proud of their cultural heritage.
Yes, you know, absolutely. So it's funny that you should say that, because I get the opposite. So I get like, well, where's your hijab? You know, you're a Muslim woman, right? Where's your hijab? And so that's a lot. I get that a lot on my TikTok. And I agree with you 100%. You know, I used to wear hijab. I wore hijab for throughout my undergraduate medical school and first year of training, you know, and then I ended up taking it off while I was in residency, but it was the same thing, right? So when I wore hijab, you know, I was this perfect Muslim, right? Even though that may not have been the case. Yeah. And then when you take it off, then like, oh my gosh, what happened? You know, why are you? So definitely there's a whole idea behind wearing hijab. And just like you said, you know, people see, oh, she wears a scarf. So, you know, does she speak English? Does she even know what I'm saying? You know, can she understand? You know, it just, right. There's
I get that from my patients. So I live in a very white Caucasian area, and a lot of the patients, when this is when I was a junior doctor, not so much now, but when I was a younger doctor, I took over from a GP who had been there for 25 years, and a phenomenal woman, absolutely phenomenal doctor. She retired, so I took over her list. And I would genuinely have patients phone the surgery just to check that A, I didn't have an accent, B, that I could speak English, because I read my name and they're like, this is a very complicated, or I would get, it's a very ethnic name. And then they would see the headscarf and they would assume that I'm not the doctor. I genuinely had a woman, I went out into a reception and I called out her name and she came by me and she said to me, oh, you're not my doctor isn't brown. And I looked at her and I just thought to myself, oh my goodness, there's this concept that a doctor is like, people still have this concept of a male, sadly a white version of it. But then on the flip side, now that I'm on social media and I wear a hijab, I'll get some people who are fascinated by the fact that I wear a hijab, and some, sadly, from people from my community, who will say, but behan hum tumhari gardan dekh sakte, we can see your neck. And you're
ridiculous.
So I realized the reason I'm sharing that story is I realized that wherever you go, the way that you look, you can't change that. You can't change the color of, well, you can change the color of your hair, but I guess you can't change anything about yourself. But I'm a brown woman wherever I will go. You're a brown woman wherever you will go.
Absolutely.
Whether dress in a bikini, or whether you wear a hijab, or whether you wear a burqa, or anything along the lines, what matters is what value you bring to that conversation that's happening in that time.
Absolutely.
You know, that's the thing that I think that constantly we should be teaching our daughters along the way, and our sons along the way, because you can't. So why should you change? So if someone says to you, sister, where's your hijab? Say to them, but the piece of cloth on my hair is not the value that I bring to a conversation. The value is what's coming out of here, because what's up here.
Absolutely. Absolutely. 100%. And that's, you know, I feel that people just get lost, right? Like they forget what you're even saying because they're so focused on what you're not, right?
Yeah.
That it doesn't matter. But
I think that back to that point of belonging, we all want to belong to something, and we all want to have an identity, and no one teaches you your identity, if that makes sense, especially if like you're a Pakistani woman in America, in New York, or a Pakistani woman in this country, but no one teaches you that the Western way, the minute you leave your house, and then the cultural values that your parents and your uncles and your aunties and your cousins and your grandparents and the heritage, you know, of your ancestors that you bring along, with all the pain and the partition and colonialism and the British Raj, all that pain comes along. And in America, it's still, you know, it's the same. And no one verbalizes that because it's something that's seen as not important, but it is, because your identity allows you to mentally feel acceptance. And then that's why we do have individuals who are then feeling lost and caught up in what you're not saying or what you are saying, because they want to be grounded all the time. And no, I'm not saying I've got the solution, because I can tell you I'm still finding ways where I feel I don't belong. So there are still moments where I think, ooh, this is not the space for me.
no, it's you know, they talk about that a lot, right? About how like centuries of well, here they specifically talk about like with African Americans and you know, Black and brown people, and how we always used to say that, you know, being African American was a risk factor for hypertension, right? But what we didn't say is that all those years of oppression, right, and all those years of racism that still persist, that you know, continues from generation to generation to generation. And so that is what, you know, makes the person a risk factor for having high blood pressure, right? Is all that mental trauma that they've experienced, right? So I think it has something to do with what you were saying about like our identity and how we bring all that with us, right? Whether or not when we leave our countries and when we come here, we still bring all of that baggage with us, right? So I think, yeah, I agree with you. I think that you have to be grounded and you have to know who you are, and then just see what value you can bring. But I also want to talk to you about everything that you've done with like women's health. I think it's amazing with all of your TikToks, and you know, you talk a lot about hormone replacement therapy. So what's like your main focus now? Is it more talking about like menopause and perimenopause, or you know, you have a special liking for menopause and all of the different treatments? So what do you like to focus on when you do like most of your reels and all of your social media?
So at the moment, I'm focusing a lot of my social media on menopause. And the reason being is because my mother is in that age group, and she'll hate me saying it. She is. And the woman that you love, and she's the woman that I love and adore, she's going to be my priority. So she is at the forefront because she's the woman that's given me everything. And for her and her friends, they're in that similar boat. And they are all women who, for some, English isn't the first language. You know, English is not their first language. They're Punjabi, and the myths around the menopause and HRT particularly, I think need to be pulled apart a little bit. Because if they're pulled apart, then we can empower women. And I think the thing that gets me is the fact that women don't seem to understand that menopause is a transition that happens to everybody. But there are statistically, I mean, this is the UK statistics, but you can be affected profoundly. So, and it starts relatively young. That's the other thing. They always think it's going to happen in my 60s and my 70s, and then that's it, and that's all I'm going to have. And so, and also it's not talked about. There's a shame, or as my mother always said, "Nighat sab kuch parde ke niche rakha kar." And I'm like, no, the parda needs to be lifted a bit. And the reason being is because if you hide something under the veil, you nullify the experience of that woman. So if she's having hot flushes, night sweats, palpitations, you know, sab kuch dukhta hai, saans se leke pair tak sab kuch dukhta hai, everything hurts, head to toe pain. If she's getting headaches, psychological symptoms, paranoia, tinnitus, the change in her mouth taste goes. And then if she's finding that she's having sexual dysfunction as well as part of it, and she's still in her 40s, and I think those are the things that are so taboo, so shameful, that we don't bring them out into the open. So when I started doing TikToks, I was actually really nervous when I started doing them. Firstly, my sister thought I was stupid. And, so my sister is a dentist, and she said to me, "Why are you on a young person's app? It's like 17 and 16-year-olds doing TikTok dances." And I was like, no, I think that the best thing to do is if you teach them young, they will teach. My plan was really that I couldn't access my women, and I say my women when I mean like South Asian women, but all women I feel are my women, but I couldn't access them through Instagram and Twitter, because Twitter they don't really read, and Instagram is very aesthetically beautiful, and I just always feel that Instagram is not real life. And whereas TikTok I could do to camera, spiel off some medical information, clip it and put it out there, and for me it felt like very little effort. It is, I mean, it's a lot of effort, don't get me wrong, and
It is.
making reels and making, I mean,
Yes.
phenomenal reels. I mean, I've watched them all. I'm like, oh my goodness, this is so good.
Yeah, tons of work.
And it's take time, and you take time out of your own schedule. And I have to find pockets of time after surgery in clinics where my 3 kids aren't running around. And I thought that if I put this out there, then the 16 and 17-year-olds who are watching this will speak to their mum and say to their mum that this is what's happening. And I did some in Urdu as well. So I did some in vaginal atrophy in Urdu and mental health stuff in Urdu as well. And along the way, I realized I don't always have the lexicon in my language in Urdu how to explain vaginal dryness. How do you say that in Punjabi or Urdu? How do you say? Yeah, exactly. You know, we've got 2 doctors on this call, and both of us are from the same heritage, and going, actually, we don't know that in our lexicon.
No, I have no idea. Yeah.
And so if you don't have the language skills to go to the doctor in the NHS system, which is set up for a 10-minute consultation, and that's all I get, and then you're sent away, and with treatment that isn't adequate, you're still left with the symptoms. And I had, so when I came to the UK, the community here took real good care of us. And there was a particular auntie, you know, sab tumhari auntie ban jati hai. Everybody's your auntie, and she was a really good auntie of mine. And she, you know, she grew me up, and she saw me through medical school. And in hindsight now, whenever I would see her at the mosque, she'd always say, everything hurts and I'm getting flushes and things. And now I know it was menopausal symptoms. She went to see her GP. Her doctor said, well, we'll run a battery of tests, all normal. But her ESR, which is a marker that we use sometimes for fibromyalgia, came back as slightly raised. And that marker came back raised, and so put her on steroids. She went out to put some clothes on a line, slipped in the snow, fracture neck of femur. Asian women, high risk of fracture neck of femur because we cover up, lack of vitamin D, put on steroids on top of that. I mean, it was an accident. She ended up she had sepsis from the fracture neck of femur. She died at the age of 52.
Oh my gosh.
And you look at that, and no, there's no mistakes. I mean, if you look at it, the care she had was lovely and brilliant. And as a Muslim woman, you think, okay, you know, Allah ki marzi. Everyone always says this. Her time was going to come, and we almost become very passive to that. And then as a clinician, I'm thinking, hang on, but we don't see that in other communities where there's better awareness of this. Why do we just sort of have to become really passive to the fact that death has happened and not actually question it? What could have been done? She could have been prevented. All she needed was some HRT. I mean, if she had some HRT, that would have protected her bones, protected her heart, and she would still be with us. And so that's not just my aunt. I mean, that could be my mum. That could be your mum. That could be your sister. And when you think of it like that, and you think this is a cycle of sab kuch parde ke niche rehna chahiye, actually that's when it's awful, because what you know as a clinician, you're not teaching to your own community. and you're not raising the awareness. And then we question ourselves going, oh, but there's worse outcomes in Black, Asian, ethnic minorities. There's worse outcomes for women. And, you know, there's higher rates of heart disease, higher rates of diabetes, high rates of dementia, blah, you know, you list it in our communities. And we think to ourselves, but where are we ever going to say enough and put in some intervention and then make the change? And that's where TikTok really came about, because I wanted to get into the family WhatsApp groups. And that's what happened. A lot of my videos got picked up by those young individuals who were doing TikTok dances and realized that that was their mum that's had those symptoms, went into the WhatsApp group. And then I think that harnessing social digital media, as you do as well, because you do it brilliantly.
Oh,
I learn from you is that this is what we need. We need to be seen, we need to be heard, and not to be scared because of everything coming out of the parda and going, what is this? But that's when change will happen. And telling women actually hormone replacement therapy is, you know, there are risks attached to it, but it's not into the context that we think it is.
So I'm interested to find out, I didn't mean to cut you off, but here in the US, you know, after the WHI study that happened, right? There's a huge hesitation. And in fact, I just went to the American College of OBGYNs. They had a meeting in San Diego, and they talk about how there's a whole generation, and that would include my generation, of OBGYNs that are very hesitant to prescribe HRT, you know, because of the risks that were found and the, you know, the possible risk of increase in breast cancer and, you know, blood clots and things like that. And, you know, what they say, and it actually came out in the Journal of American Medical Association, it was in 2020, and they talked about hormone replacement. And of course, you know, and I'm just interested to find out what they say in England, but what they said in that article was that, you know, start hormone therapy as close to menopause as you can, right? So in that 50s range, and use it for the least amount of time that you need. So for the shortest duration and the lowest dose. And they say, you know, typically you should try to wean people off within a few years of, like, say, like 5, 6 years, whatever. And that definitely you shouldn't place somebody on it like that are in their 60s, right? So start when they're in their 60s. So that's what the article said. I'm just interested to find out what, you know, what is it that you say in England and how you prescribe it. And yeah.
So we've rigorously looked at the data, and we have something called the National Institution of Clinical Excellence, NICE, which is gold standard. And in 2019, the NICE guidance for menopause has come out, and that's a combination of the British Menopause Society looking at all the data. Now, firstly, the WHI study. We need to be absolutely clear. The WHI study was focusing on synthetic forms of hormones.
Yes.
The WHI study looked at women in their 60s. Now, we know if we're looking at the risk factors that came out of there, breast cancer for one. Breast cancer is a disease of age. As we get older, our natural estrogen that we produce as women will affect the cells in our boobs. And then therefore those cells will become inflamed and change. And where you get change, you get mistakes. Where you get mistakes, you get cancer. I mean, that's the honest truth. And breast cancer is a horrific condition. I have patients who get diagnosed with breast cancer, family relatives who have breast cancer, but they're not all on HRT. So you look at that and you think, hang on, you're not even on HRT and you've got breast cancer. So surely we've got to look at the risks. And that's what people forget, that there are risks and then there's absolute risks. And then risks that are going to be in the background anyway. You cross a road, 50-50 chance you get hit by something if you don't look properly. But you reduce those risks by looking, stepping out when the traffic is light. So you have to think of medicine in that way. What are your risks that you bring along with you as an individual? What is your weight? Women who are in their 60s, who have a body mass index of over 30, have a 50% increased risk of breast cancer. If you drink 2 or more glasses of wine a night, so that's over 14 units a week, your risk of breast cancer increases far more than being on hormone replacement therapy. And then we've got to understand that hormone replacement therapy has changed along the way. So the WHO looked at synthetic forms of hormone replacement therapy. Now what we have is something known as body identical, and I think in America is known as bioidentical.
Yeah.
So hormones which are similarly replicating your own hormones, made from sort of root vegetables and yams. And they comes as gels, patches, and sprays. And you can get a micronized progesterone, which is called Utrogestan, in the progesterone form, and Cyclogest as well, which is a vaginal form of progesterone. So the studies that were done from the WHO study that says that a woman should stay on HRT at the bare minimum for the shortest period, I don't think can be transimposed from that data to what the HRTs we have now. The studies that was done, so there's a study that came out in July, actually from the American Menopause Society, that shows that women who are on body identical hormone replacement therapy, their risk of clots is not there, a reduced risk. Remember, we have a background risk anyway. 1 in 1,000, I think, roughly, will get a blood clot for no rhyme or reason. But then if you are on body identical and your risk of breast cancer and clots decreases, and if you are a woman who doesn't have a womb, being on estrogen alone doesn't increase your risk of breast cancer. Remember, I said you have a background risk anyway from the moment, because our own natural estrogen works on us. So that concept of remaining a woman, and I'm that generation of your generation where we were taught, take the woman off HRT after 5 years. That doesn't apply anymore. And that's what we need to be empowering our clinical fellows and also our patients with, to say, actually, let's look at the benefits that come with having it. So what are the benefits? And then weigh that up with your own medical history. So the benefits of having hormone replacement therapy gives you a better quality of life. The younger you start it, the better quality of life. There's more and more data from Lisa Mosconi, who's a consultant who's doing research into HRT and dementia. So we know that brain fog is real.
Yes, absolutely.
And linked to the fluctuations in estrogen and testosterone, we think as well. But that's a whole other conversation. We can come back to that. And we know that if we start estrogen or hormone replacement therapy early, then it stops the neuroplasticity that can happen with that brain fog. So actually starting younger, so in the perimenopausal phase, is a good idea. And then also we know it protects your bones. That's the biggest finding for me, is that we spend 1.3 billion pounds in the UK in the NHS on fractures. And if we can prevent that, isn't that brilliant?
Yes.
And on top of that, it actually gives you protections against heart disease. So we need estrogen as women. We always think that estrogen is this terrible hormone, but it can't be a terrible hormone because we produce it naturally. It drives our fertility. And what we need it for is because of what I've realized is estrogen is like a lubrication. We need it because it's an immune modulator. It looks after our immune system. It looks after our brain vessels. It sort of nourishes all the blood vessels around your heart. So therefore, actually lowers your blood pressure, lowers your risk of heart disease, gives you more energy to exercise, lowers your risk of type 2 diabetes, which is another huge cardiovascular risk as well. And you exercise better, and the psychological symptoms. So estrogen, we know, reduces that palpitations, the panic attacks, the self-esteem, the anxiety. And so therefore, when you look at the benefits outweighing the risks, you think, actually, does this lean towards the fact that my patient will benefit from hormone replacement therapy? And I've been a clinician now for 15 years. And I've come to the point where I have a very frank conversation with my patients. I go through their medical history, I go through their risk factors and then their benefits. And if they don't have a womb, I say, I'm just going to give you estrogen alone. If they have a womb, I give them estrogen and progesterone, and then go through the different types that we have. So, there's capsules that we have. This is micronized progesterone. This is body identical. And I give them a gel, or I will give them patches, or I will give them a spray. And if it's a gel like this, it's transdermal, goes into the fat cells, and then goes into the skin, into the bloodstream, bypasses the liver, therefore doesn't trigger off your clotting factors, and then you get benefits from it. And now we're knowing that it gives you benefits in longer term because of prevention of other diseases. So as a healthcare professional, my whole job is to prevent other diseases developing down the line. So I say to a patient, do you want to live longer in misery because of the risk of this happening with hormone replacement therapy? Or do you want to live with quality of life, even if it's shorter? And for me, as a clinician, as a woman who will go through the perimenopause and menopausal phase, I'm not too far off it, I'd rather have quality of life than live till I'm about 103 and say, yeah, but I was absolutely miserable.
So I'm wondering, how long do they say in the UK to stay on hormone replacement?
It depends on the type of hormone replacement therapy. So it's vaginal, so it's vaginal estrogen, lifelong. I don't take women off it. If I put them on it, I say you stay on it, and this is for vaginal atrophy or genital urinary syndrome of the menopause. And then if it comes to women who don't have a womb, or particularly for women who've had a bilateral salpingo-oophorectomy, so they've had their ovaries removed, and then I say to them a low dose of transdermal estrogen, so patch or gel or spray, for as long as the woman needs. I mean, they do say that after the age of about 55 or 60, the woman won't need it. But I know that some patients get flushes afterwards. So then again, you do that risk assessment, you do that risk balance assessment very carefully with that patient. It's that whole question, do you want quality of life or quantity of life? So for me, I've got some of my patients in their 70s and 80s who don't have a womb, who are on a very low dose of gel that they just put onto their thigh. And then if it's a woman that does have a womb, she's got estrogen and progesterone. So then I say to her, well, up until about 55 is probably when you need it, maybe lower than 60. So I go up to 60. And then I say to the woman, but if you wanted longer, you can. And there are different ways of having it. So as I said earlier, you can have a coil as well. So one of the other options I give women is that I say to them, look, I'm going to insert a coil like this that will go into your womb. It will take the lining of your womb away. And if you're a perimenopausal woman, it gives you contraception as well, because we're still having periods. It will protect you from endometrial cancer because the lining doesn't thicken up, and give you HRT for 5 years. In the UK, it's licensed for 5 years as a progesterone component. And I've just inserted this type of coil, a Mirena coil, looks like this, a couple of days, because I do a clinic yesterday, actually this Thursday, so I put something like this. And my patient was very fit. She was 62. So I put a Mirena in a 62-year-old. Happy days, really good. And she's going to get progesterone, and she's going to get some gel, and that's her HRT. So for me, as a clinician, it's risk versus benefits. And I don't think for me as a clinician doing menopause care, I don't put an age limit on it at all. And if you think back, we don't do that for a lot of other drugs. Like, do we statins because you've reached 60? I mean, that's ridiculous.
Yeah.
Why is there an age limit? There is no data to categorically tell you why there has to be an age limit. And I've not seen any data to show me. And so I go by an individual choice of that patient that's sitting in front of me, who is suffering with the symptoms. They are my priority, and I'm their advocate.
Yeah, that's interesting. You know, I mean, I've never put in a IUD in somebody that is menopausal, but that's interesting, right? To give that for progesterone, and it's low dose. Right?
It's very low dose. You know, Progesterone 20 micrograms, so tiny dose. So in the UK, if a woman has postmenopausal bleeding, and she's not on HRT, she'll go to her gynecologist, who will do a hysteroscopy, so take a biopsy, check that out, find out what it is. And if it's not cancer, and if there's just a lining that's thickened, they'll be either offered an ablation, so burning away the layer, and then have a Mirena coil put in to stop that lining from coming back.
Yeah.
So if we know that it's safe and it stops thickening of the lining, why wouldn't you put it into a woman and just use as an age as a discriminatory factor?
Yeah, I guess, you know, I think the thought is that, you know, you don't have the estrogen when they're menopausal, right? Estrogen growing that lining as much. So then, you know, why would you need that progesterone? But, you know, I see what you're saying about the HRT part of it.
Yeah, exactly. Because if they need it as a component of HRT, then they're working away, stops their periods. Yeah. And then they need estrogen, a small dose of it for flushes or bone protection, because it's now part of the guidelines for osteoporosis, or their palpitations, which you've had everything ruled out to say that, and you know these are menopausal symptoms. Because for me as a clinician looking after women, there is no such thing as that your symptoms go away. I still get, 60-year-olds, 70-year-olds who still come back to me and say, I've got flushes, or I've got mood symptoms, and, I've got libido issues. I've got a 22-year-old who's on her 5th husband and still wants great sex, and I'm like, why not? So
That's awesome.
it's awesome, and I think that it's having the options, right? As a doctor, it's having the confidence to have the options to give to the patient, and then weighing up the risks and benefits for that patient, and then empowering them to go away and make that choice that's suitable for them. And then I always come back and I keep saying it, is it quality of life are you after, or is it quantity of life? So if my 92-year-old said, look, I don't want any sex, then it's painful to have sex, then what's a little bit of vaginal estrogen at that age? I mean, it makes no sense. Give her the estrogen. It will help her.
Yeah. Yeah. I'm wondering also, you know, in terms of the testosterone, do you give out testosterone as well? And what's the dosage that you use?
Yeah, so testosterone is, you've hit a very contentious issue in the UK. So we have a very lovely, incredible individual who's an influencer in the UK called Davina McCall, and Kate Muir is a documentary maker, and her and Davina McCall and lots of other, I was part of the first documentary. This is the second documentary. We looked at testosterone. Now, testosterone, we know we need as women because our ovaries produce it. And as we go through change, our ovaries stop producing testosterone. And if you've got primary ovarian insufficiency, or if you've got chemical menopause, so you've got medicines that's triggered off your menopause, or you've had, your ovaries removed, then obviously you're going to lose, your testosterone levels as well. You're going to lose that hormone that you need. And we need it for our libido, our muscle mass, our bone strength. We need it for cognition. We need it for fatigue, our energy levels, and we need it a little bit to drive our metabolism as well. So the difficulty we have is that I know all these benefits that you get from having testosterone. There's only one gel which is on the market for women called Androfem. And the NHS, which is what I work for, which is a healthcare free at the point of access, won't cover that in their cost budgeting because it's really expensive. So we have the male versions of testosterone available for women at lower doses.
Okay.
The data and the studies done on women is woefully lacking. I mean, that's woefully lacking in everything. You look at heart attacks and women are not researched. It's always men's data imposed on women. But the British Menopause Society says that testosterone should be given for low libido. Once the woman has been completely estrogenized, so she's on her estrogen, you've looked at psychological factors and social factors, because remember, libido isn't just a hormonal issue, it has to be the social and psychological factors, and you've dealt with those and you still think, right, I'm not getting any better. Then we do what's known as an androgen index on a woman. So we do a blood test checking her sex-binding globulin hormone and a testosterone, free testosterone level. You calculate the androgen index. And there's a cutoff marker. If you score below, in my area where I practice, is if you score less than 1.5%. So the range that we like women to be in is between 2 and 5% of their androgen index. And if you're sort of below 1.5%, then you can have on the NHS from a specialist the male version of the testosterone. So that's Testim, Testogel, or Tostran. And that can be given in a small dose to you that you will try for 3 to 6 months to see if it makes any difference to your symptoms of libido. But this is an area which, again, I feel there's a bit of sexism involved in this area, because we're sort of saying to women, jump through all these hoops. We just need good research. Just like and I start back at endometriosis, and we just need better research to get a good diagnostic test for endometriosis. Women wouldn't have to wait 10 years for a diagnosis. And this is the same, that women should be offered, especially if they're in primary ovarian insufficiency or they've had their ovaries removed, to say, have testosterone as well, because this will look after your muscle mass, your cognition. And so the availability of testosterone in the UK does very much vary according to your patch that you live in, because there's a postcode lottery, but there are availabilities of what you can have, and then you can go privately to have the female version, which is Androfem. But I've got some really exciting news. The plan is that because now manufacturers have understood the importance of testosterone from the studies that are coming about, the fact that it does have lots of benefits and very little effect. There's no data to suggest that impacts on breast cancer, or that it impacts on the lining of the womb, causes clots or anything, because it's a gel that you put onto the skin, so it's transdermal. So that other manufacturers are now looking at making their own formulation of female testosterone, which means that there'll be a generic version, so the prices will come down. So then we're able to have that on the NHS. But again, it's that exciting frontier of medicine that we're looking at.
Yeah, I agree with you 100%. I believe definitely there needs to be more research done for women, and there definitely is not, right? And even for people of color, and it's just all the research has always been done on white males. So absolutely, you're 100% correct. Here, what they say about testosterone is that, that we should use 1/10 of the dosage that, that men get. And that, we have to look for signs of like clitoromegaly and, hirsutism and acne and all of those things, male pattern baldness, things like that.
This is not making a face, because I've been prescribing testosterone as a private GP for about 5 years. And I've been given Androfem, and I have given Testim and Tostogel as well. And honestly, I to this day, I've not seen male pattern baldness from a gel on a woman, or her voice changing into a man, because the dose is minuscule. And what we do is we do a blood test. So we do another androgen index once the woman's on treatment 3 months later to check what her percentage is. Is she between that 2 to 5%? And so, we have safety measures built in as clinicians when we start something, as we do with HRT. We do 3 monthly, 6 monthly, 12 monthly reviews of HRT. It's not something that I just feel that sort of this, it's good to be aware of that. But have you ever seen clitoral megaly on a woman that you've given testosterone to?
No, I haven't.
Yeah. But, and you've been a clinician for how long?
18 years. Yeah.
Yeah. And I think it's because what they've used the data of oral testosterone. So your muscles will build up and your Adam's apple will develop and your male button. They've used that data to write down the guidelines for the gel version, and we see that with topical vaginal estrogen. You read the pamphlet that comes with topical vaginal estrogen, you will get breast cancer, you will get clot. And it's the same. It's because there is this not attention paid to the fact that hormones given in different ways has their own, and they haven't done the research. They just treat, and this is what I think lots of people don't understand. They will, manufacturers, to get through their guidance or the guidelines for the MRHA or the FDA, will just pick those guidelines and just stomp it onto another bit. And Dr. Rachel Rubin has been campaigning really hard with the FDA, and we have in the UK with the MRHA, to say, please change your guidance around vaginal estrogen. It's just another barrier, because that's why we can't get topical vaginal estrogen, which doesn't get absorbed in your bloodstream, does not start breast cancer, does not trigger off breast cancer or recurrence of it, but in fact protects you against UTIs, protects you against having vaginal atrophy, protects you against from having sore pain, painful sex, painful smears, which in the UK we have a real issue with women uptaking their free smears. And so the benefits are so great, but yet we're denying women this by saying, oh, but it causes breast cancer. If I use vaginal estrogen, so this is Vagifem, for 1 year, it's equivalent to using 1 dose of this a day. It's tiny. And the same with testosterone. It's tiny amounts.
Yeah. Yeah, definitely. So that's currently what the American College of OBGYNs, especially, with things that are not FDA approved, they just don't have the research. And so I think they're very hesitant to, prescribe those medications that they don't have enough research for. And so they just don't advocate for it,
And that is where it comes from yourself as a clinician, myself as a clinician, reading the data, looking at the data and empowering each other as colleagues. So I talk to a lot of oncologists, and I talk to a lot to heart doctors as well, and even local gynecologists, because we just assume gynecologists know everything about HRT. And in the UK, actually, that's not the case, because menopause is its own specialism. Gynecologist is gynecology. It's a general term. And then you will find the area that you like. Exactly like as a GP, I'm a family GP. But if you came in with a shoulder problem, I probably would have a good idea what the shoulder problem is, but I'm going to send you to my colleague down the corridor who does shoulders day in, day out. That's his bread and butter. So I think that this is where there's a mismatch in people's expectations and understanding of healthcare systems. And then also empowering our colleagues out there, like oncologists, to say, if your patient who's a woman who is having, vaginal atrophy or recurrent urinary tract infections, please have the confidence to start her on vaginal estrogen, because you will save her so many trips to the hospital, urosepsis, and just painful agony, the mental health anguish that comes with that. And I think this is where social media and digital platforms, like I can virtually reach out my hand to you from across the pond and say, look at the data together, because I learn from you just as much as I learn from all the other clinicians who are practicing across the world.
Yeah. Yeah, no, I think that's so great, right? With this access that we have, and you and I are talking, and we're in different countries across the pond, right?
Well,
so, I know that we're approaching an hour, and I don't want to take up too much of your time, but maybe, another time we can talk about, I'd love to talk to you about the taboo of talking about sex, right, in our cultures, and all the importance of sex education and contraception and sexually transmitted infections and all of that stuff, right? And empowering women. And I think you have the same idea that I do, that, the more that we have education, the more we empower our women, the more that women can make, good informed decisions about their bodies and their health.
Definitely. And I think talking about sex in ethnic minority communities is really like the last taboo. We talk a lot about mental health, and we've started to talk about our bodies and breast cancer, and we started to talk about menopause, and the conversations are opening up. But the last sort of frontier as a Muslim woman, as a South Asian woman, I have to say, is that conversation around sex, because especially in the communities that I come from, we still practice a lot of arranged marriages. I mean, my own marriage was arranged marriage, but I don't ever remember ever having that conversation with my mother about sex.
Never.
The expectation, and it's something that is so taboo that even I sometimes feel I'm not comfortable talking about it. And isn't that weird? Because I talk about so much, but we need to get over that fear and that shame. And I come back to it. सब कुछ पर्दे के नीचे रहना चाहिए, that stuff there.
Yeah, no, absolutely. I think that it's a very important topic, and it's something that we do need to, especially, talk to our girls and our women, and definitely to the men. But, I think so much is like you said, पर्दे के नीचे रखें, that, we just don't know, and the women don't know, and they don't know what to expect, and they don't know what's normal and what's not normal. Right. And I think that makes it more difficult. So,
yeah, but no, happy to do that. And honestly, it's a real joy to speak to you.
Yes, I really enjoyed it as well.
So your content on talking about sex, and I know you have a podcast as well, because I tuned into it. And I think those sort of conversations are so liberating. And that's the joy of podcasts. You can listen to it in your own time when you're ironing or cooking, or, the kids are doing something, or you're out on a run or something like that. And I think that the joy of that is now harnessing social media and digital media means that we can open up the conversations for our daughters, because we don't want our daughters and our daughters' daughters and our daughters' daughters, decades down the line, having the conversations we're still having and sitting there in silence, because that just breaks my heart when I think about that. I think that's not the way it should be at all.
Absolutely. Well, thank you so much, Dr. Nighat. And I look forward to seeing more of your reels and all the other adventures that you're having. That's so amazing. So thank you. And hopefully we can schedule another time where we'll talk about sex.
Oh, my favorite topic.
Yeah. I love you too. Thank you. All right. Bye-bye. Assalamu alaikum. Thanks for listening. If you'd like to schedule a one-on-one coaching with Dr. Lodi, please visit drsadaf.com. And until next time, this is the Muslim Sex Podcast.